Second white coat. Subscribe and like. Let's learn medicine together.
Today, we're jumping right into some diagnostic detective work, solving a clinical case that all comes down to one single, crucial anatomical clue. So let's get into it.
Okay, so here's the puzzle right from the get-go. We have an 18-year-old who gets stabbed in the forearm. One nerve is completely severed. The whole case, the entire mystery, boils down to this. What specific movement can he no longer do? And this isn't just some textbook question, right? This is literally how doctors have to pinpoint these kinds of injuries in the real world.
And here it is. This is our crime scene, the anterior forearm. Now, I know it looks complicated. It's a busy neighborhood, absolutely packed with muscles, tendons, blood vessels, and nerves, the whole shebang. But don't worry, the exact location of this injury is going to give us everything we need to crack this case wide open.
All right, so let's lay out the facts of the case. Our patient is 18 years old. He's got a 4-centimeter cut on the flexor surface, that's the front of his proximal forearm. And that word proximal is key. It just means it's higher up, closer to his elbow than to his wrist. That detail is absolutely critical.
So now we're moving from the ER into the operating room. This is where the investigation really gets good, because what the surgeon finds is the single most important piece of evidence we are going to get. This is the moment that changes everything.
And there it is, our smoking gun. A nerve running between two very specific muscles, the flexor digitorum superficialis, FDS for short, and the flexor digitorum profundus, or FDP, has been totally cut. You know, in the complex map of the forearm, this is like being given a precise street address. It narrows down our list of suspects dramatically.
So let's trace the path of our mystery nerve. Follow its movements. Up near the elbow, it sneaks between the two parts of a muscle called pronator teres. But then, as it goes down the forearm, it follows this super-specific route. It runs just underneath the FDS muscle and right on top of the FDP muscle. This is our nerve's signature move, its trademark path.
So, with an anatomical pathway that unique, there's really only one nerve it can possibly be. I think we have more than enough evidence now to make a positive identification.
The injured nerve, it has to be the median nerve. That specific path, that little corridor between the FDS and FTP, that is its classic calling card in the forearm.
Now, in the medical world, this has a specific name. It's called a high median nerve injury. And that word high is all about the location. It happened up in the forearm, not low down at the wrist. And trust me, that distinction between high and low is huge, as we're about to see.
Okay, awesome. We've got our culprit. The mystery is halfway solved. But now we have to connect that nerve to what it does to figure out exactly which movement our patient has lost for good.
And let me tell you, the median nerve is a major player. It's like a main power line. It controls the muscles that move your thumb, some key muscles for your index and middle fingers, a whole bunch of the muscles that bend your wrist and fingers, and even the ones that turn your palm to face the floor. Losing it is a really big deal.
Now, with all those jobs, you might think the patient would suddenly lose a dozen different movements. But for a sharp diagnosis and to answer our big question, we're looking for that one single telltale sign, the one movement that just screams, aha, it's the median nerve. But before we deliver our final verdict, any good detective has to rule out the other suspects, right? So let's quickly check the alibis for the other major nerves in the arm and see why it couldn't have been them. And what I love about this is just how clear-cut it is. Let's look at their alibis. Supination, turning your palm up to hold a bowl of soup, that's the musculocutaneous and radial nerves. What about extending your wrist and fingers like you're telling someone to stop? That's the radial nerve's job. And adducting, or pulling your thumb and fingers together. You're looking at the ulnar nerve. None of them fit the evidence. Case closed on these guys.
So, case closed on this particular mystery. But now let's take a second to build your mental toolkit. These are the really high-yield concepts from this case that you can take with you and apply to all sorts of other situations.
First up, remember that difference between high and low injuries. A low lesion, like in carpal tunnel syndrome, happens way down at the wrist. It mainly just messes with the muscles in your hand. But a high lesion, like our patient has, that takes out everything downstream. It knocks out power to muscles in the forearm and the hand. Where the injury happens is everything. And this, right here, is probably the single biggest takeaway from this whole thing. If you ever see or read about a structure located between the FDS and FDP muscles in the forearm, your brain should immediately light up with one name: median nerve. It's an unforgettable anatomical address.
Okay, so how do you actually remember which little muscles the median nerve controls in the hand? Well, there's a classic mnemonic for this: LOAF. It stands for the lateral two lumbricals, opponent's pollices, abductor pollicis brevis, and flexor pollicis brevis. It's a super simple way to keep those key hand muscles straight.
All right, let's do a quick lightning round. Think of these as your mental shortcuts. You hear median nerve? Think thumb opposition. Ulnar nerve, think spreading your fingers apart and bringing them back together. Radial nerve, think extending your wrist, making a stop sign with your hand. And muscular cutaneous, that's your classic bicep curl. Simple, powerful, and easy to remember.
Okay, our toolkit is packed, so let's go back to our 18-year-old patient, head back to the scene of the crime, and finally answer that question we asked at the very beginning.
And here it is, the final verdict. The single definitive movement that is lost is the opposition of the thumb. That specific, almost uniquely human movement is powered by the median nerve.
So what exactly is opposition? Just so we're all on the same page. It's this amazing move right here, the ability to swing your thumb across your palm to touch the tips of your other fingers, especially your pinky. It's the movement that gives us our fine grip and dexterity.
And this is where it all just clicks into place. Deep in the base of the thumb, right here, is the opponent's pollicis muscle. Remember our LOA mnemonic? This is the O in loaf. This little muscle is the main engine for opposition, and it gets its power directly from the median nerve. So when that nerve gets cut high up in the forearm, this crucial muscle just loses its power.
So we started with a simple cut, and we ended with a very specific lost movement, all by just following a trail of anatomical clues. It really makes you think, doesn't it? What other profound clinical stories are written into the very maps of our bodies, just hidden in plain sight, waiting for us to read them?